Good day everyone, I am Victor, the moderator for this webinar. I welcome everyone for today's webinar, which is Advanced Directives Ensuring Compliance with CMS and TJC 2024. I want to introduce our presenter for today, Laura A. Dixon. Laura A. Dixon was COPIC's Director of Facility Patient Safety and Risk Management and Operations from 2014 to 2020. Ms. Dixon has over 20 years of clinical experience in acute care facilities, including critical care, coronary care, pre-operative services, and pain management. I would now like to hand over the floor to the speaker. Over to you, Laura.
Okay, thank you very much, Victor, and welcome everyone. We've got quite a bit of information to cover today, so I'm going to get started pretty quickly, but I do want to point out two email addresses you might want to keep in your little library, and that happens to be those for CMS. There are multiple areas that affect advanced directives, and it's not just CMS conditions of participation. We have federal laws, we have state laws, and for those of you who have Joint Commission accreditation, you have those standards for which you have to meet. And there are multiple types of advanced directives. It's depending on what you want to call them. Well, let's do a brief overview of some of the cases in the law that came out from this. So Karen Ann Quinlan, this was the very first case that talked about permanent vegetative state. One thing we definitely need to know is who is and who is not a DNR. A couple other cases of note. So I want to talk about end-of-life planning. This is the physician's responsibility. We have to tell the patients what they need to know about medical intervention. There are two CPT codes. So in October 15, well, it's almost 10 years ago, Medicare is now paying for those consultations. And they even added a couple months later that they will add that to the physician payment rules. This really they found it did improve outcomes for your hospital. CMS, they added 19 quality measures for the physician to report, to focus on patient care. Well, let's talk some federal law on advanced directive. In a nutshell, it's called the Patient Self-Determination Act. And that means the advanced directive is any written document that recognizes under state law, whether it's statutory, by courts, however it is, talking about health care when an individual is incapacitated and they can't make those decisions. The idea behind this act was so we could tell patients, hey, these are your rights to care. So generally it applies to any Medicare certified hospital, skilled nursing, home health, hospice, HMO. If you're taking Medicare payments, it's going to apply to you. So what we have to do is give them written information on what's their decision for decision-making rights. Yes, you have to have written policy and procedures on how you're going to implement that right. But since then, it's now been almost 25 years since the PSD went into effect. I want to talk deficiencies very briefly. Now, this is in the patient rights section of Appendix A. So what were some of these deficiencies? All right, I'm going to now move over to the actual conditions of participation. Again, we're talking Appendix A. It is in the patient rights section in A. The surveyors, what they're going to do on advanced directives. So first off, we have to give required notice to patients. So as far as notice to the patient and their representative, what you tell the patient extends to that representative. If you have that incompetent or incapacitated patient, you may even have a state law that designates who is that patient representative. So moving on, our next tag number, and these are all for now in the A appendix. Patients have a right to make decisions on their care on consent. If the patient is not competent, it's the same thing. If the person shows up with an advanced directive, whatever you want to call it, you get consent from them. Make informed decisions, but that means they have to be informed. We've already mentioned it can be any type of written instrument. As far as the content and delegation, well, we know what does the patient want or not want. Have a hospital policy. It must be written and it must be provided that we give this information at the time of admission. The patient rights are also in the Joint Commission. So again, the CMS, there is a provision for allowing it, and it is very narrowly focused. Overall, if the patient has an advanced directive, we want to document. We can't condition treatment. Otherwise, we educate them, not only the patient, but the staff and community education. So I did mention visitation and notice, but likewise, no designation of a representative. It's whoever shows up and asserts it. Talks about advanced directives and surgery. And then finally, if we're going to transfer a patient, please send it with them. If they're going to long-term care, that's the acute hospitals. Very quickly on critical access hospitals, you pretty much have one tag. Specifically talks about advanced directives. You have to provide information to the competent patient when they're admitted. You can't require one. We have to educate our staff on the policies regarding advanced directives. Part of this included Joint Commission standards. It's a document that allows someone to make decisions and give directions about their future care. The standard, it's in the rights section for Joint Commission. Number one, you have and follow your written policy and procedures on advanced directives. Number 9, you document if the patient has or does not have one. In the record, now this is another one. First was the rights section, this is now record of care. So now I mentioned at the beginning, we'd talk about some position statements. These are the professional organizations that talk about somewhere along the line, advanced directives and the patient's right to choose. American College of Anesthesiologists has really good information, counsel on surgical and perioperative safety. As far as PACU and ASPAN, nurses follow the standards of care, and they have 4 recommendations. And 4, this is the one that may come up more often than we would like to see. Suggestions and other statement. ASAP, American College of Emergency Physicians. American College of Surgeons talk about if you have policies that either lead to automatic enforcement, that they say automatically suspending them, undermines that self-determination. We have to respect their autonomy. Physician and anesthesia, document those issues. Other ones, we have the Emergency Nurses Association, their resuscitative decision. AMA, they talk about out-of-hospital DNR systems. It's a national approach to end-of-life planning and that conversation. Again, in the appendix, I have about 20-some pages of these resources that you can get into. Well, again, these are very tough decisions that we have to make, and sometimes we have to make them very quickly, and we know they're going to be permanent. So that's it for me. Thank you, Victor. If anyone has questions after the fact that you've come up with it, send them over to Victor. He will get them to me and I can respond back to Victor. Thank you, everyone. I'll give you have about 20 minutes back. Time for a coffee or another refreshment. So thank you, Victor. I'll let you end it all.
Thank you, Laura. So that does conclude the session for today. That was a good session, and thank you very much all the participants. You may all disconnect now. Thank you very much.